Hey, it's Calvin again. This video is about medication for cough. This is not a hypothesis video as I usually make. It is quite a straightforward video. You can watch this if you are a doctor. It will be useful in approaching cough. Also, if you are interested in medical research, but do avoid if you are a patient, it might scare you. So, on with it. So, the four phases of cough are irritation, inspiration, compression, and expiration. How does coughing occur? Sensory stimulation to the mucosa of the pharynx. So, sensory stimulation, this is the mucosa of the pharynx having all these goblet cells and mucus secreting cells. And sensory stimulation of these nerve endings which penetrate down to the epithelial cells. These nerve endings extend down to the mucosa and extend up to the subcortical region of the brain. And there is a clear distinction in the voluntary and involuntary neurons of the cough reflex. Here are pictures of coughing, talking, and swallowing. The first picture is a picture of coughing, second picture is a picture of talking, the third picture is a picture of swallowing. So, coughing and talking would require the larynx to open and close, while swallowing closes the entire windpipe with the epiglottis. Can't swallow while coughing, high chances are to aspirate. And I also emphasize sniffing the sputum out on a hanky. Sniffing it back can cause reinfection, reuptake of cytokines, increasing the inflammation. So physiology involves irritation, inspiration, compression, and expiration. Irritation involves Irritation involves the irritation of mucosa by foreign body or any other stimulant or any other pathogen. Pathogens are too small, but any other stimulant. Irritation of mucosa can irritate the nerve endings of penetrating to the mucosa and to reach the subcortical nucleus of the human brain. And as soon as irritation is over, the brain will stimulate a deep inspiration phase. The the diaphragmatic muscles and the intercostal muscles will open the thorax to the maximum level, and all the air will go inside with the opening of the glottis by the vocal cords. And after this there is a closure of the glottis by the vocal cords. After the vocal cords and the glottis is closed, all the high pressure expiratory power would be stored, and sudden expiration will happen. The storage phase of power and pressure is called compression, and the sudden expiratory phase, forced expiratory phase, causes cough. There are three types of cough, basically two types of cough: productive cough, dry cough, and hemoptysis. Hemoptysis is blood in cough. Blood in cough can is one sign that we have to go to the doctor, we have to go to a specialist because it could be a dangerous pathology. Dry cough could be anything, could be from a viral infection to a irritation through down the throat, or it could be asthmatic. Productive cough almost always, especially colored sputum, almost always indicates bacterial infection. So once a patient comes to you with the cough, or any relative comes to you with cough, we have to ask for the onset. When did it start? Duration, associated symptoms such as fever, whether he is producing any sputum along with the cough, or is he breathless, uh, and cough is getting exasperated, and if there is chest pain and blood in sputum is hemoptysis. And on examination, we have to look at the oropharynx, open his mouth with the torch, and examine the tonsils and the reddening and any plaque or mucus, extra mucus deposition in the oral cavity, and tonsils if they're inflamed or changed into reddish in color. An auscultation of the chest, if it's a auscultation of chest, will give an idea about lower respiratory tract infection and the condition of the lung, whether if it's irritated or inflamed or any other pathology such as pneumonia. Color of the sputum will give an idea of the organism, or if it's a bacterial or a viral infection or just an allergy. Usually, yellow color gives us a suspicion of bacterial infection, and green color gives us a suspicion of Pseudomonas, which is an opportunistic pathogen, and white sputum also gives an idea of bacterial infection, and while colorless sputum might be just allergy or viral infection. And sputum microscopy would be required for gram staining and acid fast staining to find out what pathogen is causing it. Chest X-ray would give a great idea of the lung condition, lower respiratory condition, and lung biopsy and CT in advanced cases. So here are diagrams of the vocal cord, how it opens and closes. So various muscles and nerves take part in opening and closing of the vocal cord. The vocal cord is opened and closed by reflex actions, and this determines whether the airway is open or closed. Two important factors is the epiglottis, which closes the windpipe completely while swallowing, and the vocal cord while we talk and when we cough or aspirate, it closes and opens in accordance to whether uh, a foreign particle enters the lung or not, enters the trachea or not. It is the gatekeeper of the trachea. So the muscles involved in opening and closing of the larynx, and the inspiration and expiration is given in this slide. So inspiration is caused by intercostal muscles, diaphragm, which are supplied by the intercostal nerves, vagus nerve and the phrenic nerve, while the larynx is opened by geniohyoid, mylohyoid, sternothyroid and middle constrictor. These these muscles, with their names, we can find out where their muscles are. For example, sternohyoid means it is between the sternum and the hyoid bone. So larynx is closed by thyrohyoid, cricohyoid, sternohyoid, and inferior constrictor. So once again, the muscles here, while exhalation and inhalation, they open and close the vocal cord, and connecting these bony and cartilaginous structures are the muscles of the larynx. So nerves involved. So larynx is opened by geniohyoid, mylohyoid, sternothyroid, and middle constrictor, and closed by all these muscles. And all of these nerves originate from the vagus nerve, which is the 10th cranial nerve, to the C3 nerve, C3 vertebral nerve, and they give rise to a plexus called cervical plexus, which give ansa cervicalis. Some of these nerves are supplied by hypoglossal nerve, which is the 12th cranial nerve, and some of these muscles are supplied by C1, C2, C3, and some by a vagus nerve directly from the 10th cranial nerve. Spinal accessory nerve is not involved in this part of the body, this part of the neck and the throat, and the glossopharyngeal nerve is only has functions on swallowing. It doesn't have much function on down to uh, cough reflex. So nerve supply of the larynx is comprehensively given in this diagram. You can pause to check and study it. So now getting down to the main subject, espionage list. How we tackle this problem of cough. Here's a summary of what we are going to see now. Uh, First, we look for beta 2 agonism causing bronchodilation. So beta 2 agonism is on the bronchial smooth muscles. Beta 2 receptors are on the bronchial smooth muscles. Molecules like adrenaline and salbutamol, salmeterol, terbutaline, they act as agonists to these receptors and stimulate it, causing relaxation of the smooth muscles on the bronchus and thus causing bronchodilation. So when the bronchus is dilated, the air flow improves due to more space in the lungs, in the bronchus. So histamine 1 receptor. Histamine is a major culprit for unwanted inflammatory reactions and unwanted hypersensitivity reactions. Type 1 hypersensitivity reaction has its basis on histamine. Histamine 1 receptor blockers specifically, we can target these receptors such that there is less sedative effect. Like histamine 1 receptors, when we block them, we might get sedative effect. We might get less stimulated in general, and we might feel sleepy. So selective histamine 1 receptors can be designed in order to avoid these receptors and just focus on reducing the inflammation. Stimulation of surfactant synthesis. Once we stimulate surfactants, once we stimulate surfactants, we get decreased mucosal thickness and increased mucosal mobility. So once these surfactants uh, like sodium ions and chloride ions are secreted on the mucosa, there is increased flow through of the mucosa, and accumulation of phlegm and sputum is decreased, and respiratory surface tension is decreased, so that respiration occurs easily. So thinning of mucosa is another direct method. We can use lozenges and molecules that reduce the mucopolysaccharide thickness, decrease the viscosity. Decreasing viscosity means decreasing the frictional force between layers of the fluid, which is sputum or the mucosa, thus causing increased mobility outside and through the lungs and out of the lungs of foreign material or pathogenic material, rendering the lung easy to function. Antimicrobials. It might be upper respiratory tract infection, lower respiratory tract infection. We use various antimicrobials, antifungals, antivirals, antibacterials to tackle the problem of microbe-induced cough. Sigma opioid receptor activators. These again, just like histamine 1 receptor blockers, we can use these opioid receptor activators. Instead of blocking histamine 1 receptors, we can activate sigma opioid receptors, which again will cause sleep. But if we use selective sigma opioid receptors, we can avoid the sleepiness and tiredness and just focus on the decrease of inflammatory reaction. Mucokinetics and increasing productive cough. Thinning of mucosa is one thing, and mucokinetics is the increase in movement of the mucus and increase in movement of the sputum. Stimulation of alpha 1 receptors on blood vessels, constricting them. If we stimulate alpha 1 adrenergic receptors, there will be vasoconstriction. So vasoconstriction will cause decreased inflammation just by decreasing fenestration and decreasing output of the WBC cells into the inflammatory area. Anti-inflammatory NSAIDs and steroids. NSAIDs like paracetamol can be used to decrease inflammation which is causing cough, and steroids on a higher level can be used if it is more of a threatening condition like corona COVID. And here's a drug list of the drugs we are going to talk about: dextromethorphan, ambroxol, alex combination, doxycycline and ambroxol, AB-Flow SR combination, cherry cough syrup, foracort, buracort, syrup ascoril, benadryl, cefodime, clarithromycin, Alercet, which is phenylephrine, levocetirizine, Otrivin, which is xylometazoline, and augmentin, which is amoxicillin and clavulanic acid. So cetirizine is a H1 antagonist, so can be used in allergies and as they are mast cell mediated. So mast cell, while being activated by a IgE antibody, it regranulates and produces a lot of inflammatory cytokines. This can be inhibited by cetirizine. So chlorpheniramine maleate, H1 receptor antagonist, histamine 1 receptor antagonist. Histamine 1 receptors are present throughout the central nervous system. So this drug might be a smaller drug which can uh, penetrate through the blood-brain barrier. If you notice carefully, you can see two phenol-like rings. These phenol-like rings usually increase the permeability to lipids, which means they are more of a polar molecules. Polar molecules, they are more lipid soluble than water soluble. Arousal and awakening will be decreased actually. Thalamus will be decreased because we are blocking a stimulatory neurotransmitter, and his H1 receptors, they on agonism they cause arousal and awakening and stimulation of thalamus, cortex, cerebral cortex, cholinergic neurons, serotonergic nuclei, cholinergic nuclei, and dopaminergic nuclei, blocks the action of. Now these are the nuclei. These are the nuclei which are stimulated by the H1 receptors, and while using chlorpheniramine maleate, the receptors are antagonized and blocked. So their functions will be stopped for some time, and the cough reflex will be decreased. And H1 receptor is located also in mast cells, as I told before. And here's the mechanism of action of histamine. On receptors, it works on H1 and phospholipase C and protein kinase C and calcium stimulation and biological activity. It goes into the nucleus and it works on the transcription, translation, and furthermore production of neurotransmitters. H2, H3, H4, they work on a different mechanism of action. We are not using these stimulant drugs. We are avoiding H2, H3, and H4 receptors when it comes to cough. Levocetirizine. Levocetirizine, there is less sedating than cetirizine. The only difference between levocetirizine and cetirizine is the molecular structure, and we are avoiding the sedating receptors of the same H1 uh, receptor domain. All the sedating areas of the brain we avoid, and it also requires a lower dose. And the structure is almost the same as cetirizine. And Benadryl. Benadryl is diphenhydramine, again H1 receptor agonist, antagonist, competitive inhibitor of histamine, and could be used for insomnia. It could be used for insomnia. It will help you sleep. With Benadryl, we use it for children who are quite aggressive and resisting treatment, slightly painful treatments. You just sedate them with the Benadryl. And Benadryl, we are not like levocetirizine. We are not inhibiting uh, the inhibition of sedating histamine receptors. So dextromethorphan. Now we move to antitussive drugs. Antitussive drugs, what they do is work on sigma opioid receptors. They are not of analgesic and addictive properties. Sigma opioid receptors are in the endoplasmic reticulum of the olfactory bulb, hypothalamus, Purkinje cells of the brain. Basically, nerves. Sigma opioid receptors on the nerves, nervous endoplasmic reticulums, and also of the endoplasmic reticulum of oligodendrocytes, which are glial cells, supporting cells of the nerves. They decrease coughing. And these dextram antitussives, they can cause blood-brain barrier. Again, we see a phenol ring, common denominator. Same phenol ring is a polar molecules cross the blood-brain barrier and work on endoplasmic reticulum on the sigma opioid receptors, and they decrease coughing by complex mechanisms. And the complex mechanism is explained here. Alpha 1 receptor on the nerve terminal and inflammatory allergens, they competitively inhibit the inflammatory allergens. Ambroxol. Ambroxol. Stimulation of surfactant synthesis is another technique that we are using. We take the type 2 pneumocytes of the lung, and the type 2 pneumocytes of the lung produce surfactants, which actually causes soapy, increases soapy nature of the mucosa of the lung, thus decreasing surface tension in the alveoli, thus making respiration easier. So it also makes the mucosa more uh, more thin and less viscous. It thus facilitating expectoration, increasing mucus clearance, and thus producing mucokinetic and secretagogue properties. As we see here, the mucolytic and expectorant properties, they smoothen the lung, soothen it, and thus causing increased clearance of the dirt and dust the lung has. So this ambroxol could be used by lysosomal technology. It could touch the selectively reach the type 2 pneumocyte and cause reaction and production of surfactants. And ambroxol was tried for SARS-CoV-2. SARS-CoV-2, it works on acid sphingomyelinase in the type 2 pneumocytes, and it moves in the lateral direction to reach the receptors of the angiotensin converting enzyme 2 of the lung of type 2 pneumocytes, thus competitively inhibiting the function and increasing surfactant synthesis instead of decreasing surfactant synthesis by the destruction of type 2 pneumocytes by coronavirus. So Alex is a syrup. It's a proprietary name, brand name, and it is a combination of dextromethorphan, which we discussed earlier, and phenylephrine and chlorpheniramine. Phenylephrine. Phenylephrine is an alpha-1 adrenergic receptor agonist. So what these alpha-1 adrenergic receptor agonists do is they cause vasoconstriction. They have a G protein coupled receptor, inositol triphosphate pathway, increase intracellular calcium, and cause contraction of the smooth muscle, thus causing contraction of the vascular smooth muscle, causing vasoconstriction. So, vasoconstriction will further decrease inflammation by decreasing the fenestration and decreasing the diapedesis of WBCs and decreasing the receptor value of cytokines. So here's the mechanism. Norepinephrine is what is the actual natural alpha 1 2 inhibitor. Sorry, stimulator agonist. Instead of norepinephrine, we use other drugs to stimulate the inositol triphosphate pathway and cause contraction. So next thing is another alpha synthesis sympathetic agonist, which is xylomethazolin, which is Otrivin, is a brand name. An alpha sympathetic agonist causes vasoconstriction again in the nasal mucosa. We use this as drops and cause decreases of decreased vasodilation and increased vasoconstriction of Kieselbach's plexus and causing decreased nasal allergy, nasal itchiness, and decreased inflammation. And Nacevion is oxymetazoline, alpha 1, alpha 2. It works about an alpha 1, alpha 2 sympathetic agonist and vasoconstriction of mucosal blood vessels, reducing allergy and vasodilation. So, probable side effects of alpha 1 receptors is on the blood. It may go on to act on the eye, bladder, prostate, and uterus. Alpha 1 on the pupils causes uterus, pupillar dilatation, pylorus of the stomach. It could cause contraction and urine contraction of the urinary sphincter also. So doxyphilin. Doxyphilin is a xanthine molecule. It is a bronchodilator and doxyphilin also works on beta 2 receptors. It is an anti-inflammatory. It it causes smooth muscle relaxation and it is a phosphodiesterase inhibitor. Phosphodiesterase is an intracellular messenger that causes smooth muscle relaxation. I think doxyphilin is causes blood brain. Sorry, doxyphilin causes uh, doxyphilin can penetrate through the cell membrane and works inside the cell. It is not a beta 2 agonist, as I said. It is not a beta 2 agonist. Beta 2 agonists work on the cell membrane on beta 2 receptors. Doxyphilin works on phosphodiesterase enzyme. It is an intracellular receptor, intracellular enzyme inhibitor, causing causing bronchodilation, just like salbutamol, but in an intracellular pathway. Acebrophilin. Acebrophilin stimulates surfactant synthesis in the type 2 pneumocyte and causing mucolytic mucus thinner and easier respiration. Cherikov. Cherikov is a combination of three drugs and it is a brand name commonly used. Guaifencin. Guaifencin is a mucolytic agent like mucociliary clearance. If we this turquoise blue part of the mucus, if we decrease its viscosity by mucolysis, like if we break the mucopolysaccharide bonds, uh, which is what it is made up of. It is mucus is always a carbohydrate, which is mucopolysaccharide. When these mucopolysaccharides weaker bonds are broken, they become loose, and the viscosity, which is the intermolecular and interlayer friction in the fluid, if it is reduced, the clearance by the cilia will increase, and the mucus becomes watery secretion, and it is easily expelled out of the lungs and pharynx. Salbutamol. Salbutamol is the major beta 2 specific G protein coupled receptor. It comes in the brand name Astelin. It is very commonly used. So this G protein coupled receptor is a serpentine 7 protein 7 pass receptor, which is bound to G alpha and which stimulates adenyl cyclase, which simulates phosphokinase A, which causes smooth muscle relaxation by blocking the calcium entry into the cell. It causes bronchodilation. Here it is. So intracellular calcium inhibited, inhibition of myosin, inhibition of phosphorylation of myosin, which is the major Hansen and Huxley major part of the muscle filament, which according to Hansen and Huxley's hypothesis works to constrict the muscle by binding to troponins and pulling the actin filaments to shrink the muscle and contracting it using the power of calcium and ATP. And inhibiting the calcium, we get by inhibiting calcium, we get to bronchodilate by loosening the muscles of the bronchus. So foracort is a combination of formoterol and budesonide. Budesonide is a steroid. Formoterol, just like salbutamol, is a long-acting beta-2 agonist, adrenergic agonist. It might be slightly longer acting than acetylene or salbutamol. It persists for 12 long hours, and beta 2 is, as I already said, is coupled to G protein, which stimulates adrenal cyclase, as I showed in the diagram, causes smooth muscle relaxation. So beta 2 agonist kinetics. So when we insert the drug through inhalation by respules or orally, the drug enters the bronchus, and the bronchial smooth muscle will have a cell wall like this. It will sit on these drugs, albuterol, formoterol, and salbutamol, these terbutaline, these drugs, they sit on this phospholipid membrane, and they move towards the receptor. And so depending on whether it is lipid soluble or water soluble, hydrophilic or lipophilic or amphiphilic, it will bind to this lipid and won't let go. So the time required to reach this 7-pass receptor is increased in hydrophilic compounds, while the binding force to the 7-point receptor due to this lipid membrane is for longer duration because it attaches adjacent to the receptor, and the total duration is long, but the binding time required is also long in drugs which are lipophilic like salmeterol. Budesonide. Budesonide is an anti-inflammatory glucocorticoid. So now we are going into steroids. Steroids always have intracellular receptors. Corticosteroids have reduced inflammation through intracellular receptors. That is because steroids are again have multiple phenolic and closed group polar compounds, chained compounds, uh, chain molecules to form the larger molecule which are steroids. They are polar in nature. So, in being polar, they always are more lipophilic. Steroids are more lipophilic, and they pass through the cell membrane and reach the intracellular receptor, and gene repression occurs, and thus transcription and translation decreases. Transcription and translation decreases, and the inflammatory proteins are decreased. Thus, total inflammation decreases. Budecort is a budesonide nebulizer. It can be taken through inhalational respules. So, Ascoril is also a commonly prescribed medication. Ascoril is a combination of bromhexin, guaifenesin, and terbutaline. Bromhexin is a basic mucolytic. As I also before explained, it decreases the viscosity between two layers of the mucus or the sputum, and thus causes by mucopolysaccharide inhibition effect, breaking, fragmenting, and thinning the mucopolysaccharide bonds, and thus increasing the volume and decreasing the viscosity of the sputum, thus causing increased ciliary clearance away from the lung. Terbutaline. Terbutaline is an anti-asthmatic. So even in asthma condition, we can use terbutaline. Again, it's a beta 2 adrenergic agonist, and it's short acting. Short acting again means it will bind to the beta 2 receptor very fast because it is more hydrophilic. But lipophilic drugs will be long acting, but binding to the receptor of beta 2 receptor will take more time. Now here coming to antibiotics. Cepodyne, which is combination of cepodoxime and potassium clavinate. Cepodoxime is a third generation cephalosporin, and potassium clavinate is a beta lactamase inhibitor. Cefodoxime, as it works on pneumonia and sinusitis, sometimes works on gonorrhea also, gonococcus also, and transpeptidase cell wall. The transpeptidase protein is inhibited by this membrane, and this transpeptidase is very specific to uh, gram positive cocci, I mean gram positive bacteria, which is just two layers of peptidoglycan layers, just two peptidoglycan layers, and this transpeptidase, if it is inhibited, the cell wall of the bacteria cannot be produced. Thus, this bacteria will get lysed. This is a bacteriolytic drug, very similar to penicillin. Clavilnate. Clavilnate inhibits beta lactamase. So, what this beta lactamase is? The enzyme is a enzyme specific to bacteria. This bacteria produces beta lactamase, which destroys the uh, antibiotic given against it. When the beta lactam enzyme is inhibited by clavulinate, which is a beta lactamase inhibitor, the beta lactam drug, which is the penicillin or cephalosporin or amoxicillin, it works better. It works again because there is no beta lactamase to destroy the drug. So augmentin is a combination of amoxicillin and again clavulanic acid. Amoxicillin is a modified uh, amino and oxy group are added, and it is very similar to penicillin. So works on the inhibition of bacterial cell wall synthesis, and by inhibiting the cell wall synthesis of the bacteria gets lysed, destroyed and killed. And clarithromycin is a more complex drug by its chemical structure. Clarithromycin is the macrolide antibiotic. No, it's not macrolide. Clarithromycin is a drug. Chemical structure does not provide a macrol ring, that is very apparent. But clarithromycin is a 50S ribosome inhibitor. 50S ribosome inhibitor, and this ribosomal structure is specific to bacteria. It specifically targets bacterial 50S ribosomes, and thus it can work against gram negative bacteria equally efficiently. Uh, so protein synthesis of the bacteria is stopped, and the bacteria stops functioning. It doesn't die actually, it is more of a bacteriostatic drug. So thanks for listening. I'm very grateful that you came to this slide at the end of this, and thanks a lot.